I am Miki Fuji, a plastic surgeon from Japan. I am researching about the efficacy of MRI to diagnose osteomyelitis. Dr. Jeffcotti used my paper in your slide. Thank you so much. In my opinion, in my report, I showed MRI can show the localization of osteomyelitis.
What's the question? Yeah.
I think we should use MRI not only to diagnose osteomyelitis, but to know real extent localization of osteomyelitis. What do you think about that?
The question was, we should use MRI not just to diagnose osteomyelitis, but to determine the extent of osteomyelitis. I quite agree. It's obviously part of routine practice to do that, so I agree with you. Thank you for raising the point.
Thank you so much.
Yes?
Hi. I've got a question for the panel to do with management of osteomyelitis as diagnosed by a sample taken in theatre. So for me as a surgeon, you've got an infected wound, you debride. I then change my sterile gloves, get a separate set of instruments, and take a nibble off the bone and send that separately as a clean sample. It comes back as positive. Now the interesting is, this is not surgically infected. This is crunchy bone. Okay, so I would normally expect nothing to be growing on it, but often that's not the case. It comes back as growing something. Do we believe it? One, and number two, when we treat it, how long for? Thank you.
I'll take a crack at that. So this issue has been raised a number of times in the literature, and there's been one study that I'm aware of that looked at the outcome of treating or not treating with infected bone or with bone that is cultural, positive on culture. And it looks as if you do it with sterile instruments, changing the instruments as you say, and the organisms grow from the bone, that if you don't treat, they go on to develop osteomyelitis signs and symptoms. And so the current recommendation is that if the bone culture is positive, you probably should treat them as osteomyelitis and presume that you've left behind infected bone and therefore the usual 4 to 6 weeks of therapy. But it's based upon a not very well designed retrospective trial. Warren or William, do you have any other experience with that?
So what do we do in the case? There was one slide where we had a protruding first empty joint coming out through the wound. For us, in our times at the Deaconess, that it wasn't just osteomyelitis, but to get the patient excised, closed, and back to using a usable foot. Can we reach some consensus, because we have medical plus surgical up here? To me, it's relieving not only potential bone infection, but also trying to get rid of the prominence that got the patient in trouble to begin with. Warren, why don't we start with you?
Well, I think that the first thing we have to get rid of is this overwhelming consensus that's out there based on absolutely nothing, that the treatment of osteomyelitis is 4 to 6 weeks of IV therapy. If you've got a surgical resection, and it's an aggressive surgical resection, there's no reason why those courses of therapy can't be shorter. If you've got an osteomyelitis of a toe and you amputate the toe, what we say in the guidelines is that you don't need any antibiotic or treat a soft tissue infection for 1 week. I think we have to get away. Overall, there's not a lot of good evidence to support or to inform duration of therapy. I know William's study looked at one duration of therapy, Eric's looked at another. Everyone's looking at different durations of therapy. I think the bottom line I would have is we need to start customizing durations of therapy, because that's a basic principle of antimicrobial stewardship, but we just have to get away from this rote 4 to 6 week of IV thing.
I'd just add to what Warren has said. There have been 2 studies now that have compared 6 weeks of antibiotic therapy to 12 weeks of antibiotic therapy. One was in diabetic foot infections with osteomyelitis by Eric Seneville. The other was in spine osteomyelitis. Both showed that 12 weeks was no better than 6 weeks and associated with more complications. So there's no reason to treat for more than 6 weeks. How much less than 6 weeks we can treat for is not clear, but my own belief is that probably we will be able to shorten that. The second thing I would say in regards to what Warren said is that there's an ongoing trial now in England that's looking at IV versus oral therapy. We've randomized over 800 patients to IV or oral antibiotic therapy for complex musculoskeletal infections, mostly osteomyelitis. There's a data safety monitoring board that has not stopped the study, so the chances are that if there's any difference between IV and oral, it's extremely small.
Well, but we're not answering the question. So you have a bony prominence either on the dorsal and the plantar surface of the foot. Why not just excise the osteo and limit your antibiotics?
Well, I did say that. I mean, that's exactly what I said. I said that, if you do remove the bone, then you limit the amount of antibiotics you need. There's no question. I think that's been shown. There have been a couple of studies that have looked at that. One in Journal of Foot and Ankle Surgery. I don't remember if that's Dr. Meyer's work or not. If he's here, he could address that. But the point is that if you remove all the infected bone, you don't need any antibiotics. If you remove part of the infected bone, you may still need some, but not the 4 to 6 weeks.
Right.
So I think surgery does play a major role. But to actually come up to you and say, for a patient who has surgery, you need only 4 weeks versus 6 weeks. There's nothing to inform that. It has to be personalized, I think.
Right. Why don't we keep going down and then we'll...
I think it's very important for us not to separate into two camps of being surgeons or non-surgeons. Non-surgeons being people who give antibiotics for long periods of time, perhaps thoughtlessly, might be the way. We work together. There are two approaches to the management of disease, surgery and antibiotics, and we choose the right treatment, the appropriate treatment for the appropriate person, for each person.
Great. Chris?
That hallux is not doing very much at all. So my thought would be, if you want to get it closed quickly, you use part of that hallux to close the wound, assuming, I don't know whether that bone was infected or not. So, it would depend on the x-ray and the way the wound looks on.
Right.
What we would do is just take off the toe, use part of that flesh to close the wound, save the metatarsal if you can, and you're done. So it's patient-centered. Dr. Armstrong.
Wonderful talks, lady and gents. And terrific moderation, may I say. You're looking great. But just maybe to follow up on that, let us assume now that we've cut out that bone, and we think we might have a clean margin. We always get a clean margin. We send it for path, not for a culture for our clean margin, but we get a culture of the dirty bone and path. But might that not be a place? Let's say that it's staph. Let's say we've maybe even done something slick and clever, like maybe Dr. Lipsky would talk about, like community profiling or PCR, and we've identified this predominantly staph. Might that not be a place to try? Putting in a phage therapy, delivering it locally as a sentinel. You mentioned that this might be hanging around a little bit. The trouble is, I think so much of this is fascinating, and it captures the imagination. And there's this great historical value, and it makes some of us so enthusiastic. But where do you think that might be a place for it, but where do you think things are going to go, or is this just going to be you running around the world, being the lone, carrying the torch for this thing?
I don't think that's what's going to happen. And I know that, for example, that there is a little company in Portugal that has just put together a package of 2 staph, 2 pseudomonas, and 1, I forget what Acinetobacter, I think, that's been approved for clinical study in the U.S. But I don't know how long it's going to take. I see this as a way of helping to move more quickly towards, but it's certainly not something where I'm the only one
But maybe for some of
these
sort of mild infections where we are treating ourselves as much as we're treating the patient. Maybe it's truly.
Yeah.
Maybe these are the patients in whom this might play a role in reducing antibiotic use.
That's the major thing that I see there, is reducing antibiotic use and reducing all of the upsets in the organism.
Yeah, thank you for excellent presentations. I think my dilemma is the patients that we see in our clinic is septic arthritis. And if we're moving these antibiotics from 12 weeks to 6 weeks, is that indicated with a septic arthritis?
I'm not clear on the question. You're saying if it's septic arthritis and you're not sure if there's bone involvement?
Yeah, so if we see a patient with septic arthritis, the Centerville study that you mentioned, is that in the presence of septic arthritis from 12 weeks to 6 weeks with the antibiotic duration? So can we still treat over that 6-week period in the presence of septic arthritis?
So most studies of septic arthritis are done in children and people where they've got hematogenic spread of organisms to the joint, and in that situation you certainly don't need 6 weeks of antibiotic therapy. Usually 2 weeks would be plenty of time for that. On the other hand, where we see septic arthritis in the diabetic foot, it's more likely to be a contiguous spread of infection or an open joint. And it may be difficult to know whether the infection came from the bone into the joint, in which case you do have osteomyelitis. So it's a much more complex situation. I think that normally if you've got an open joint with septic arthritis, my presumption would be that probably there's bone involved, and unless you can exclude that, I would probably treat as if it were osteomyelitis. Chris, you see a fair amount of this. What do you think?
Well, we don't... So the first diagnosis, obviously, to try to, we always call orthopedics to tap those joints, and if there's no bone destruction, then we try to treat with IV antibiotics for sure. But if there's bone destruction, then you're sort of stuck, and you may have to be more aggressive surgically. But that we don't see very many juveniles. We just see diabetics, and if they're infected joints, they're usually the bone's also affected.
But Chris, with the contiguous spread, again, time is tissue. If you're going to follow those, what is your parameters for then going ahead and doing something surgically? What are the parameters that you're watching?
Well, it really depends on the biomechanics. Generally, if you can perform surgically without damaging the biomechanics and get the problem solved quickly, otherwise, then you would go ahead and do that. Once you start having to remove part of the foot, etc., then it becomes much more, or the leg, then you have to be much more judicious. But function sort of drives what you do.
So I think we should conclude there. Again, we'd like to invite everyone to look at the abstracts, and again, we begin at 7 a.m. I'd like to thank the panel, and I'd like to thank the audience. You've really persisted. Thank you.